Ashwini Rawat, and I have a board certification in both electrophysiology and electrodiagnosis and orthopedics and musculoskeletal sonography. So in my practice, I combine both electrodiagnosis and ultrasonography. So although the intent of this program or this presentation is to talk about the neuromusculoskeletal ultrasound, I will also be like mentioning how we integrate electrodiagnosis with ultrasonography. When you use both together, you can see complete picture. So these are the objectives of the talk today, to identify nerve sonor anatomy, identify the common peripheral nerve entrapment sites and how sonography helps narrow down the differential diagnosis, and to understand the importance of scanning non-neural structures at potential sources of pathology. So there are many cases where we when we scan the vicinity of the nerve, it may not be the nerve itself. It may be something surrounding structure that may be compressing the nerve. So in that case, it becomes important to check the surrounding soft tissue structures and to look for any potential source of space occupying lesion. Also to put everything together, like integrate everything, know the role of ultrasound in differential diagnosis and assessment of severity of peripheral nerve pathology. So why we use ultrasound in the assessment of nerves, peripheral nerves? We use ultrasound or prefer ultrasonography over other imaging because of the resolution that we get. The resolution that ultrasound provides is considerably like much detailed than what we see with MRI. MRI is great for like overall view of the region, but when you have to look at nerve at a certain site, you prefer ultrasound because you can see the changes in the signal, texture, or any of the contour change. Like for example, if the nerve is becoming more flattened, there's a constriction site, you can see that with ultrasound. Now, most of the peripheral nerves run a superficial course, which means it becomes easy to see these nerves with ultrasound. If you put the probe there, you can see the nerves clearly there. So even if the deeper site are still accessible with ultrasound, we rarely run into the problem where nerve is hiding behind a bone, so that is not a problem with ultrasonography. Now, there are common sites of entrapment. We are specifically talking about upper extremities, and the most common entrapment site in human body is the carpal tunnel. So the most common entrapment neuropathy that we see is carpal tunnel syndrome, followed by cubital tunnel syndrome. So these are the two most common and most frequently seen entrapment sites. Then there are other sites, but these are the most common ones. Now, when we look at ultrasound, we can also see the fascicular pattern, which is the internal anatomy of the or internal architecture of the nerve. That can be studied very well with ultrasound. We can follow the nerve. Nerve can be followed from proximal to distal, which is not something that we usually do with an MRI. You get a rigid framework like sagittal, coronal, or transverse view, and you can see the nerve, but it's very easy to follow the nerve with ultrasound with a probe because you can be very structure specific. Now, there's another technique, MR neurography. I would say that would be like something which is nerve specific. So that would be superior than just simple MRI. Now, ultrasound can also see other structures, other soft tissue structures, as I mentioned earlier. Sometimes it's other soft tissue structure that's compressing the nerve. And it can be in the vicinity. So in carpal tunnel, there are a lot more other soft tissue structures that are surrounding the nerve, like tendons. And these tendons can sometimes show some pathology, maybe tenosynovitis, or there may be a ganglion cyst uh, originating from these tendons, and that can also compress the nerve. And this can be picked up with ultrasound. So let's look at the internal architecture of the nerve. So here is a nice illustration on the right. You can see different connective tissue layers. So the outermost layer is called epineurium, which is the outer envelope of the nerve. Then you can see bundles of nerve surrounded by perineurium. So you can see this is the perineurium. and perineurium is surrounding the nerve bundles. And inside the perineurium, we have several bundles of nerve fibers, again surrounded by another layer called endoneurium. So endoneurium is the innermost, followed by perineurium and then epineurium. This is also on the left side, we have electron microscope image of the nerve, and you can see there is, this is perineurium, and those are endoneurium, and then we are too zoomed in to see the epineurium. So this is the same architecture that we see with ultrasound. So again, photomicrograph of the median nerve, which makes sense. You have the outer layer, epineurium, then you have fascicular bundles lined by perineurium, and then endoneurium is inside. That's just too tiny, too small to see with ultrasound. So here is the corresponding ultrasound image, and you can see the epineurium is the brightest layer that we see around the nerve. Then perineurium is what we see as hyperechoic or echogenic bundles or echogenic envelope, where nerve fascicular fibers or the fibers within the fascicles are surrounded by. So with ultrasound, we can see the epineurium and perineurium. So here is another view with a higher frequency probe. So if you go higher, like 18 to 20 megahertz, you can see much more resolution. So you can see, although like you can appreciate here that there is some definition, or the fascicular pattern can be seen here. You can see that this is much more clear, this image. And the difference is not, the difference is basically the frequency of probe that we're using. So the higher the frequency you use, the more detail you see. So here we have long axis view or longitudinal section of the nerve. And you can see this is the uh, outermost layer, which is denoted here by the dotted lines. And that would be considered epineurium. And then you have these striations of alternating hypo and hyperechoic lines. So hypoechoic line is the, or band is the nerve fascicle, and hyperechoic interface is the connective tissue framework, which would be perineurium. Bottom image, we see this typical honeycomb or fascicular pattern, or we also call it starry night. So there are three descriptions for this type of appearance. We call it honeycomb, we call it fascicular pattern, or we call it starry night. So these all are synonymous. You may have heard of one or other, or maybe all three of them. It's essentially saying the same thing what we see here, which is that you can see the internal architecture of the nerve, and you can see this bundle of hypoechoic nerve surrounded by hyperechoic connective tissue framework. Now, depending on which frequency probe you use, if you use a lower frequency, it tends to look more like starry night. If you use a higher frequency, it tends to look more honeycomb or fascicular. Now, honeycomb and fascicular word can be used interchangeably. They mean the same thing. Like you can see these like bundles or hypoechoic regions within the nerve surrounded by bright layer. So nerves are also prone to anisotropy artifact, which you may be very well aware of if you use ultrasound. Tendons exhibit that more than nerves, but nerves can also show. And it makes sense because if you look at the nerve here, it has this arrangement when everything is running in one direction. Whenever there is an internal preference of how the structures or internal architecture runs, there is always a chance of that structure showing anisotropy artifact on ultrasound. So that is something that we see in nerves. So in distally more distally, nerve fascicles are more parallel, but there are certain sites, and usually tends to be more proximal than anything, than any other region. It can be like sometimes crisscrossing and being like plexiform. So what it means is that the certain area, so this is median nerve fascicle and distal forearm, it can be more like linear, cord-like. If you follow the median nerve more proximal, they sometimes crisscross. So why I'm mentioning this is because if for certain sites, we already know that the fibers are going to be, or fascicles within the nerve are going to crisscross versus stay more parallel. This is important because you may see more internally darker signal versus nicely defined honeycomb texture based on which region you're looking at. So some examples of this is coming in next couple of slides. ulnar nerve at the medial epicondyle can show hyperquick signal. If you compare it with the other like median nerve or distal aspect where we see the ulnar nerve, it tends to show like slightly darker texture or signal than any other region, and that's because of the inherent anisotropy at that site. So this is the slide where I have mentioned like how we put everything together. Now, in as clinicians, we don't see things in isolation. You don't just like see a patient and you just use one tool. You first thing first, the basics are basics and they are the foundation, which is the examination of the patient. So you take the history, you perform the examination that you will be doing. No matter what kind of diagnostic test you start performing, they never replace what you do in standard practice. So physical examination cannot be replaced by any fancy diagnostic exam. We need to perform the basics well. So you examine the patient, maybe perform some clinical test, examination, which includes objective test, subjective test, history taking, system review, maybe some type of like special physical examination testing. And then you pick a diagnostic test, which can be uh, EMG or ultrasound, or maybe both in some cases. So we can perform both EMG and ultrasound in assessments of peripheral nerve pathology. And so what we see is like we perform the physical examination where we identify, do we need to perform ultrasound, EMG, or both? And then you will perform an EMG if you want to know about the function of the nerve, which is electrophysiology assessment, which tells us everything in terms of pathophysiology, like what kind of lesion. Are we looking at demyelinating lesion, or are we looking at axonal lesion? Is it more proximal process, distal process? All those pathophysiology severity assessment that can be seen with that can be assessed with uh, electrodiagnostic testing. Now, you may add ultrasound because you want to know what's going on in terms of structure. Is it like nerve problem? Is it some surrounding soft tissue structure that's causing the nerve problem? So ultrasound gives us a structural perspective, like what is happening in terms of like nerve structure or surrounding of the nerve. It does not tell you about uh, pathophysiology or I would not say like all the time, because sometimes pathophysiology, but it does not tell you the severity grading, because the severity grading clinically does not correlate very well with the nerve size. There are some indicator, but in severity assessment, I would say EMG is the gold standard. So these are the common nerve entrapment sites or nerve entrapment syndromes. I have also included some lower extremity, although we are mostly talking about upper extremity here. So carpal tunnel syndrome being the most common entrapment uh, syndrome in the human body. That's always the most common one. Then we have cubital tunnel syndrome, which is ulnar nerve compression at the elbow site, followed by ulnar nerve entrapment at the Guyon's canal. We can also see radial tunnel syndrome or posterior interosseous nerve syndrome, anterior interosseous nerve syndrome, suprascapular nerve entrapment at the either at the suprascapular notch or sphenoglenoid notch. Then we may also see tarsal tunnel syndrome in the lower extremity, peroneal nerve, or you may call it common fibular nerve entrapment at the fibular head level or neck level. Then piriformis syndrome, where sciatic nerve gets compressed there. So these are some of the entrapment sites, and the most common ones are the first two. So let's look at some of the examples here. So this is median nerve illustration and also scanning. So we start by locating median nerve, and for that we place the probe transversely on the anterior aspect of the wrist at the pisiform level. We identify the pisiform, that's first thing first. Next to the pisiform, we can also see ulnar nerve and ulnar artery. Then we bring our attention to the flexor retinaculum. Under the flexor retinaculum, we can see the median nerve. So here is the clip. So here is the median nerve. We tilt the probe back and forth to check the anisotropy, which affects the tendons more than the nerve. See, the nerve is more so hypoechoic, where tendons becomes hyper and hypo depending on the tilt of the probe. After you have identified the nerve, you rotate the probe to go long axis on this nerve. So you can see that nerve is elongating now. And that's the long axis view of this nerve here. I can see this is the nerve, and you can see the tendons underneath. So that's long axis view of the nerve. It is relatively darker compared to the tendons underneath, and the course of the nerve should be uniform. So you can see like it's uniform, it's even texture, the thickness is uniform throughout as it's entering the carpal tunnel. So this is what we expect in a normal wrist. Now this is ulnar nerve at the medial elbow. So here we have three sites, retroepicondylar at the medial epicondyle and in the cubital tunnel, which is the area where nerve is surrounded by the flexor carpi ulnaris. So retroepicondylar, you can see like it goes slightly proximal to the medial epicondyle level, and you can see the nerve sitting just by the bone there. Then we keep the probe between medial epicondyle and olecranon, and same thing, you find the nerve closer to the medial epicondyle. When the nerve enters the two heads of FCU through the arcuate ligament, you will see the nerve as brighter outer line and then hypoechoic fascicles inside. So this is a normal appearance. So it's the same nerve, same neural texture or neural structure, but you can see different signal here. So it's more hypoechoic here and it's hyperechoic here. I think I see some questions or something. Oh, so the sound is a bit low. Sorry. Um, I hope the sound is okay.
Yeah, it's okay.
Okay. Um, all right, let's go. Yeah, so you can see like all three sides, and the nerve is slightly like nerve is not same in all like these sides, especially like distal portion and then the proximal. It's more darker proximally, and it starts to show more texture distally. In long axis view, again, this is a tricky area, so you have to see the course of the nerve and follow the nerve in the long axis view. It's not going in straight line parallel, so you have to follow wherever the nerve is going. So this is a nerve where it wraps around the medial epicondyle, and here is the nerve entering the flexor carpi ulnaris, and when it enters, because it's surrounded by muscle tissue, it starts to show texture. And ultrasound is all about the mismatch of acoustic impedance. Like if a structure is surrounded by a darker looking structures, it tends to look clear or in great resolution versus if it's surrounded by a brighter structure. So that's why it's like much clear in around the muscle, and it can be like little fuzzy when it's around the medial epicondyle. All right, so now after we examine the nerve in short and long axis view, we also look for ulnar nerve instability, which means does it move over the medial epicondyle, and we do that by asking patient to flex their elbow. So here is the ulnar nerve. This is the medial epicondyle right here. We ask the patient to flex their elbow to reach the end range flexion, and then see how the nerve moves. So in normal elbows where there is no laxity or instability, the nerve moves up close to the medial epicondyle, but it stays there. It does not jump out of the groove. It's normal for nerve to reach the very top, in the same level and within the groove, but at very top. Like as you can see, this nerve is like uh, from here it has moved up more superficial, and you also bring some muscle in here. This is end range flexion, but it's not moving on top of the tip of the medial epicondyle or anterior to it. So that's what that can be considered normal. Now, going back to median nerve, nerve mobility can also be checked in carpal tunnel, and that is also something that we look for, any type of mobility restrictions. So, median nerve mobility is negatively correlated with severity of carpal tunnel syndrome. Uh, We look at the static images, short and long axis view, and we see the enlargement of the nerve, which we measure by measuring the cross-sectional area. So when we see the cross-sectional area, um, that has that has a highest or a good sensitivity and specificity, about like 85% and more. And anything above 85% is pretty good as a clinical test. So cross-sectional area measurement at the distal wrist crease is an accurate parameter in assessment of carpal tunnel syndrome and has higher sensitivity and specificity. So mobility assessment, let's look at that grading scale. So this is the grading scale of mobility assessment of the nerve, where 2 is normal, which means median nerves move side to side and also dives deeper, which means it's talking about two types of movement in the side to side plane and anterior to posterior plane. Um, when there is carpal tunnel syndrome, the nerve movement may get restricted. So the median nerve, if it moves freely in the transverse plane, but it does not dive deep, that means it's the movement is restricted, and we call it slightly decreased and graded as 1. When the movement is restricted in both the planes, mediolateral and anterior posterior, so there is minimal movement in all direction, that will be called 0, which means decrease. So as you can see, this is a qualitative assessment. It's not like, it's more of a quality assessment. So you have to like look at lot many normal movement of the nerve to get an idea of like what, how would you grade 1 and 0. So I'll show you an example of a healthy nerve which moves very well in the carpal tunnel versus something that a nerve which is restricted, so that would be considered 0. So this is a transverse view of the carpal tunnel. That's pisiform on the right. Uh, that's scaphoid on the left. You can see the median nerve is a hypoechoic structure. This is the flexor retinaculum right here. And you can see the ulnar artery and ulnar nerve right here. Now this is a clip. We go to the same tunnel. This is the median nerve. You ask the patient to flex their finger or make a fist. So when they flex their finger or make a fist, see how the nerve is moving side to side, and it also becomes more like triangular. The triangular shape is essentially attempt of nerve to dive deep. So it gets surrounded by the tendons. So you can see we see both the planes of movement. We see side to side movement, and we also see this down movement. Let's play it one more time. So you will see side to side movement, and then you also see this downward movement. So we need to see both of these movements. Now let's look at the carpal tunnel, where there is carpal tunnel syndrome, and you can see the nerve is so swollen. It's enlarged, it's swollen. So now if we ask this patient to flex their fingers or make a fist, this is the movement you get. Now, looking at the previous clip, you can see that the median nerve is hardly moving here. The movement is mostly from these tendons. The nerve is almost like stuck here with flexor retinaculum. It's not really moving much. Any movement that you detect within the nerve is a relative movement of tendons just trying to push it. But by itself, it's adherent there. It's not moving well. So this can be another dynamic assessment or something that you can add to your uh, ultrasound examination. This is also another where post-surgically, when you scan a nerve and it does not show normal cross-sectional area, it's going to take for a long time for it to show less cross-sectional area, or sometimes it may never go back to the reference range of the below normal reference range. But if you check the mobility, like this is the nerve right here, and you will see that the nerve is moving. You can see that side to side movement and the downward movement. So that can be seen in this clip, side to side and downward movement. It's not restricted anymore, although it does still looks on a bigger side. And again, that's not, we don't see immediate return to normal cross-sectional area after surgery. So that is going to be there. That's expected finding. So what do we see when there is carpal tunnel syndrome or focal entrapment? We see the change in echo pattern. So on the left, we have a normal healthy nerve. On the right, we have diffusely hypoechoic nerve. So, and there is loss of that fascicular pattern, and that's the change in echopathology. Nerve swelling and enlargement is also seen. So you can see the nerve cross-sectional area has increased. When you see in long axis, you can see the swelling, and this is the constriction site right here. So uh, in summary, we see nerve enlargement. Nerve becomes large at the site of compression, like proximal to the constriction site. We see change in echo pattern, which we see in this image right here. The echo pattern is not preserved. And we see physical constriction or hourglass deformity, or sometimes we call it flattening of the nerve. So we see constriction site and we see swelling proximal to that. So these are the classic feature or typical features of nerve entrapment, and this can be applied in various sites within the upper extremity. So although our talk is more structured or more focused on carpal tunnel region and cubital tunnel region, but these features can be applied to other sites in upper extremity. So here is median nerve. Cross-sectional area is 0.19 centimeter square. We use 0.09 centimeter square as a cutoff. So that's larger than that. Then we go long axis and you can see the tapering of the nerve and swelling proximal to that. So that's finding in support of carpal tunnel syndrome or entrapment neuropathy. Here is another example of constriction, but you can see this is much more subtle compared to the previous one. So if you see that there's a sudden drop in that uh, caliber of the nerve, so there's sudden flattening here. But here there is flattening, but it's constriction. So this would be something like, maybe you may see early on. So there can be severe like grading of like how much compression do you see there. So you can see that this is the constriction site, and nerve is slightly swollen compared to this site and this area right here. So that is the constriction or physical constriction or deformity. So why we see hypoechoic signal can be explained by the pathophysiology within the nerve. So what happens when when nerve is compressed at a site? When the nerve is compressed, there is increased permeability of endoneural vessels. Okay. So when the nerve is compressed, there is increased permeability of endoneural vessels, which leads to endoneural edema, which leads to increase in an endoneural fluid pressure, which causes further obstruction of vasculature and injury to the nerve fiber. So it's the change in permeability of the internal interneural vessels. There are small, tiny vessels within the nerve, and those vessels can cause this engorgement or congestion within the nerve, and that what appears to be uh, hypoechoic swollen nerve. So this is the explanation for why we see that swollen hypoechoic nerve. Now, in chronic changes, or when there is uh, more of like prolonged or long-standing changes, we also start to see fibrosis, thickening of perineum and endothelial layer, and these can also lead to other changes. So when we see like axonal degeneration, there will be loss of echo pattern. So some of these changes later on that we see are because of axonal degeneration and chronic changes. Okay, so I see that there we have one question here come up. I'm going to, if it's okay, I'll answer all the questions at the end. So we go through the presentation and then we take all the questions. But yeah, you can keep sending those questions in Q&A. I'll answer them all at the end. So let's look at some of the case examples. This is a 57-year-old female involved in motor vehicle accidents 12 days ago before they presented to the clinic, and they had contusion of the left wrist, developed numbness, tingling in first three digit. EMG showed conduction block of sensory fibers of median nerve. Motor studies were normal. So CMAPs were normal, but sensory nerve conduction studies were showing conduction block of the sensory fibers. Now remember, this is a motor vehicle accident, so more like an acute change 12 days ago. So these are like, symptoms that are rapidly forming and they did not have these symptoms before the accident. So this is the image of the nerve. This is what nerve look like in short axis. This is what it looked like in long axis. You can see the swelling, compression site here. So that's typical for carpal tunnel syndrome. But if you look at the references and see the topography of the nerve, which means how the fascicles are arranged at this site, this explains what we see in EMG. So you can see this at this side, the nerve bundles are arranged like this. The red that you see are sensory bundles, and the green that you see, those are motor fibers. Now, if you look at this nerve, the more hypoechoic areas are localized to the sensory part, and the motor part shows the texture which we expect in a nerve. So this is explaining that endoneural edema compressing the sensory fibers, presenting as conduction block on EMG, although the motor fibers are preserved and are showing normal studies. So this is the cascade of nerve compression. This is well studied in carpal tunnel. We know for carpal tunnel, we don't know for other sites. But if there is a 20 to 30 milligram of mercury, like if these are the pressure measurements, right? So if the pressure measurement is between 20 to 30 millimeter of mercury, there is reduced epidural blood flow. If it goes to 30 and above, it causes impaired axonal transport and changes in the endoneural fluid pressure. If it goes up to like 40 millimeter of mercury, there are symptoms of paresthesia. So before patient presents with symptoms, there are some changes that's happening, but it has to exceed that threshold for the symptoms to present. Now, when it reaches 50 millimeter of mercury, the epidural edema and axonal transport gets blocked. More than 60 millimeter of mercury, there is total interneural ischemia with complete conduction block followed by complete motor block. So there is always like sensory block followed by motor block, which is exactly what we saw in this case, previous case that I explained. So in chronic cases, if it becomes long-standing, this vascular causation is superseded by other processes like fibrosis, and we see other changes than fibrotic changes in the nerve. Another case here, this is a 47-year-old male with complaints of numbness, tingling in the right first three digits in the median nerve distribution. This happened after an episode of him like working around the house and hitting the PVC pipe with the volar aspect of the wrist. So he was like just like hitting it with that, like working around the house, fixing things. Now, after that, he developed mild to moderate. He developed median nerve symptoms. On EMG, it showed mild to moderate sensory motor demyelinating neuropathic process affecting bilateral median nerves. So his study was positive bilaterally. Now, how do you know that this is like specific to right side? Because EMG is saying he has carpal tunnel syndrome is the same grade and is present bilaterally. But in addition to showing that it's a mild to moderate bilateral carpal tunnel syndrome, it also showed that there is a conduction block of sensory fibers. So we know that in acute processes, first thing we see is like conduction block of sensory fibers. So here is the image. You can see this is the nerve right here. And that site of impact where he was like hitting against his wrist on the volar aspect, you can see that local edema in that area. So although like clinically you would say, okay, this is a carpal tunnel syndrome, but we know the etiology is different and how it happened was different. There's a direct trauma over that nerve, blunt trauma, but that process of like, pressing against with the volar aspect of the wrist can irritate the nerve and can also like affect the nerve fibers there. So here is this like focal area where you can see the increased hypoechoic signal, but the rest of the nerve looks normal. So it's more localized to that area, some kind of micro injury to the vessels there, micro vessels. Another case here. So this is a 47-year-old male with numbness in the left first three digit. Again, this is a typical median representation. And but he feels mostly in the third digit and pain radiating from wrist to forearm. So pain going in the distal direction towards the third digit and pain also going towards the forearm. The symptoms duration was like about 2.5 months. So he's been experiencing this for 2.5 months. And they also had history of some laceration to the third digit couple months ago, which resulted in stiffness. So you can see like it's a confusing picture. Yes, there is presentation consistent with carpal tunnel syndrome, but we also have history of some laceration to the digit, which you can easily dismiss and say, okay, maybe it's because of the injury. He has like stiffness there. There is also pain radiating proximal. So I don't know, maybe like there is some component of proximal involvement, or there may be some radiation away from that area. So that can be like, it can be a confusing picture because although this is like typical for median neuropathy at the wrist, but there is also like other confounding factors here. So EMG and NCS studies showed moderate sensory motor demyelinating neuropathic process affecting left median nerve at or about the wrist. So you may just say, okay, my work is done here. Clinically they are showing median neuropathy, and electrophysiologically we did pick it up, and so it looks like yes, we have answered our question. And here, um, this is what it is. It's a moderate carpal tunnel syndrome. Patient clinical history presents with these symptoms which are consistent with that. EMG further confirmed it. We don't have to like really look for anything else, but I'll show you what ultrasound showed. So yes, there is some slight evidence, very mild. It's not like it, there's nothing like um too obvious here. Like it's a slight. I mean, I don't have the cross-sectional area measurements included here. It's a slight increase. It's not like significant. You can see it's more or less normal. It can even be called borderline. Long axis, yes, there is some focal hypoechoic changes, and you can possibly say this is like probably some constriction, but it's mostly a normal uniform caliber. There are many subclinical cases where people do not have compression, or they do not have symptoms, but they may still show these kind of pictures. So it's not, ultrasound is not really adding up. It's not consistent with the presentation in EMG. I mean, there you can say that okay, maybe I see something and it is what it is, but when you scan the nerve, you always go and scan that segment. You don't just stay focused on that typical compression side, which we are showing. It's not really showing any significant classic features of carpal tunnel syndrome. So you go a little bit proximal, you go a little bit distal, so you don't miss anything. So in this case, we did go distal. And when you go distal, this is what it showed. This is the palm area. As you can see, this is the placement of the probe. This is short axis, this is long axis, and look at this big swelling of the nerve. This enlargement is happening at the site where the nerve becomes a digital nerve, which means this is the site where you should not see even like the main trunk of that median nerve. You see the nerve splitting into like multiple branches, and we see this like this big swelling. So that is a intraneural fibroma of the nerve, which is mostly affecting the sensory fibers going to the third digit. So you can see like how we can be biased, and because this patient had a history of laceration that has nothing to do with this fibroma. It's just like just coincidence that this is happening and contributing to the symptoms of the third digit. But you do have to sometimes go distal and proximal, and see why the clinical picture is not matching with the diagnostic tools here. So other possible causes of nerve entrapment syndrome are ganglion cyst or intraneural cyst. Tenosynovitis of the tendon around the nerve um, can be potential sources of compression. Any other space occupying lesion, they can also cause compression of the nerve in the especially narrow area. Anomalous muscles. Now, with anomalous muscle, I would say you have to be careful because not every anomalous muscle is a abnormal finding. We call them anomalous muscle because they are not present in everyone. Certain patient, certain population has it, and it's normal. It's a normal finding. They have this extra muscle. That's their normal anatomy. But when these extra muscles are present in certain sites, they can become a potential source of compression if that person is involved in a type of occupation where they use that muscle a lot. But Let's say if that muscle was not a concern in the way it works and the action of that muscle, it's very well as be like, as any muscle in the human body. So with anomalous muscle, you have to be careful. Not every anomalous muscle is a normal finding, or not a potential source of pathology. So let's look at this example of space occupying lesions. This is carpal tunnel. Probe is placed short axis over the wrist. This is the ganglion cyst, and that's the nerve. And look at this brightness here. And if you are performing ultrasound, or you have, uh, you if this is part of your practice, this artifact is posterior enhancement, and we see that whenever there's a fluid containing area. So this is a ganglion cyst, that's the enhancement. So this is the cyst, that's the nerve. This cyst is occupying carpal tunnel. And the carpal tunnel is not a very like free area. It's a very busy area, a very tightly packed area. There isn't much room for anything there. So we have tendons. We have 9 tendons and a nerve traveling through this tunnel, and they are very well like they're that's the only space that tunnel has is for the nerve and the tendons. So anything that extra sits there can be increased growth or swelling of the muscle tendon, which can be tenosynovitis, or an extra muscle belly sitting there, or this gangliocyst. It's putting pressure, it's increasing the volume of the carpal tunnel. When there is increase in volume of the carpal tunnel, nerve is the most pressure sensitive structure, right? So tendons to a certain extent can accommodate that pressure. They may be, in terms of what we feel, patients may feel just like some stiffness moving their fingers and closing the fist, but it's not really like very pressure sensitive. So you don't have these symptoms of like numbness, tingling, pain, um, happen if it was just 10. But because we have a nerve traveling there, and nerves are pressure sensitive structures like blood vessels, uh, this can be a potential source for carpal tunnel syndrome. So this is the short axis. In this view here, we have long axis. You can see this tendon is attached to one of the tendons. And on the radial side, we have flexor pollicis longus tendon. And this cyst is sitting on top of the tendon. And you can see it's increasing the volume of the carpal tunnel. So it's a ganglion cyst arising from sheath of flexor pollicis longus. Another case of numbness in ulnar aspect of the fourth digit. So it's a fourth digit, and then the numbness is on the ulnar aspect. So this sounds like ulnar distribution, and everything was negative, and EMG was inconclusive because there is no carpal tunnel syndrome. There is no ulnar neuropathy at the wrist or at the proximal side, which is medial elbow. So we cleared that. EMG was negative, inconclusive. Upon doing ultrasound, median nerve and ulnar nerve were normal. Median nerve at the wrist, ulnar nerve at the elbow, and the Guyon's canal was normal in appearance. Then going a little bit distal in the digit itself. So you go in the digit, short axis and long axis. So short axis, this is the tendon, flexor tendon of the fourth digit. So you see this like this round hypoechoic mass. That's what we see in short axis. When we go long axis, we see this image. This is the same mass in long axis view. You can see it's next to a blood vessel. And actually, if you see, this is a little bit of connection with that normal nerve. So this is the site where we are seeing neurolemoma. So this is a nerve tumor affecting the digital nerve of the ulnar aspect of the fourth digit. So that's a neurolemoma. So, or you can also call it schwannoma. So that's nerve sheath tumor, which internally compress the fibers of the nerves. There is no external compression. It's just the tumor or proliferation of the tissue, more specifically Schwann cell, that's compressing the nerve and causing these symptoms. So that's a neurolemoma. So this is the value of ultrasound, where uh, when the typical sites where we look for this entrapment, and they're not really like answering your question, then you don't see the evidence of focal entrapment. You have to move away like a little bit proximal and distal to over the segment of the nerve, and then see maybe there is some other pathology which can sometimes mimic entrapment syndromes. Uh, Now let's look at like a couple examples of ulnar nerve. We talked a lot about median nerve. So same principles or findings apply in the ulnar nerve in the medial elbow. We are short axis, so this is the medial epicondyle, that's the ulnar nerve, which is big and enlarged. When we go long axis, we see this is the ulnar nerve. You can see this is thicker or more swollen proximally. This is the site of compression, which coincides with this the arcuate ligament where nerve enters the cubital tunnel. So that's the constriction site. So we see constriction site, which is physical constriction, hourglass deformity. We see the swelling, we see the loss of texture. So we see all the features here. So this is typical for ulnar nerve entrapment at elbow. That's where we see the entrapment site. This is a panoramic view of another case, more significant, more compression. And as you can see, there's a constriction site here. You can see normal texture distal to that site, and there is swelling proximal to that site. So there is almost like this engorgement. So if you remember those pathophysiological process of like endoneurial edema, how that happens because there's compression, which leads to um, change in permeability of vessels, which again leads to like more accumulation of that fluid in that area, and it goes into this vicious cycle. So that's exactly what we are seeing here. So that's like like endoneurial edema in this area. So that's compression site, constriction site, swelling proximal to the site of compression. Now, ultrasound has a sensitivity of 80.5%. Nerve conduction studies have sensitivity of 70.7%. And if you combine them, they have sensitivity of 85.4% in diagnosing ulnar neuropathy. So it is recommended that you use EMGs and ultrasound together in the diagnosis of ulnar neuropathy. Now, if you use nerve conduction study as a reference standard, ultrasound can reach sensitivity of 93% and specificity of 50% in diagnostic ultrasound. And the sensitivity can reach 77.3% and specificity 42.2 in localizing ulnar neuropathy at the elbow. So the message here is like when you combine two, you increase the sensitivity specificity, but at the same time, you learn a lot more because EMG will tell you the electrophysiology or function of the nerve. Ultrasound will tell you the structure of the nerve or structurally what's going on. It may not always give you the um, details of the pathophysiology or electrophysiology, but it will tell you the structural changes. And some of the structural changes can be attributed to different pathophysiology that's happening in different disease processes. So both of them together, they are pretty strong tools in diagnosis of peripheral nerve disorders. And that was my last case. And thank you very much for your attention. I would be happy to answer your questions. I did see some of the questions already coming in. So let's look at those. Okay, so I hope the sound problem was already fixed. So I'm
Yeah.
gonna just, all right. So first question is, how should the patient keep their upper limb when examining the ulnar nerve? So this is a very good question. So what I do is I never flex. So you need elbow flexion, but I never flex it beyond 60 degrees. I keep it like 60 and maybe sometimes even 45. The reason I don't flex it beyond 60 because we don't realize about literature reports about 15 to 47% of the population has asymptomatic laxity of ulnar nerve. So by the time you take them to 90 degree, some of them already have ulnar nerve move on top of the medial epicondyle or anterior to it. So you won't find it in the groove. So I'm gonna quickly go back to that slide of ulnar nerve. All right, so here, see in this case here, this is the medial epicondyle and that's the ulnar nerve right here. When you flex the elbow, the nerve moves on top of it. Actually, let's look at that clip here. See this is the ulnar nerve right here. Now this in this person they have intact retinaculum. there is no congenital absence, partial absence of the retinaculum. So the nerve is not going to go anywhere, even if you could take them to end range of flexion. But many people asymptomatic, they don't have any symptoms, you have no way of knowing that they are subluxing unless you palpate it or you scan it. By the time you are 90-degree, their nerve is already sitting here or here. So if you bridge this area and you're trying to look for the nerve in this group, you won't find it. So I would say like keep like 60 degrees or less, not more than that. Okay.
Okay.
Thank you.
Can I ask Dr. Rawat?
Sure.
Okay. I'm so excited to this great presentation as usual, Dr. Rawat. But what about the impact of power Doppler? I
Yeah.
think, yeah,
Mhm.
in acute stage of CT carpal tunnel syndrome.
Yeah, so I did not include the information of power Doppler because most of the people who are using ultrasound. So power Doppler is a great tool, and you can see increase. So that speaks to the same thing here when we say that there is intraneural.
Yeah, that's it.
When we say the increased blood flow,
Mhm.
which is what's happening here when there's enlargement, right? So with yeah, you do see increased flow and power Doppler. Now, not every machine has power Doppler, and also like when you have power Doppler, not every power Doppler is sensitive enough to pick up. Now, think these vessels are very small. So if
Mhm.
you have sensitive power Doppler, or if you have power Doppler in your machine, I would always use it. So that gives you like hyperemia or increased blood flow, which you will see it here. Yeah. So
Yeah.
that is a good indicator in if you have to use that.
I think nowadays we have a lot of scientific works about the elastography. Elastography, what this,
Elastography, yes.
yeah, elastography in
Yeah.
an assessment of the stiffness of the nerve. I think, what about your idea about this technique?
Yeah, so that speaks to, like, again, I did not include the elastography portion in this talk, but that speaks to this stiffness part.
Yeah.
So when you have, so like, this example of when we looked at, I think that was previous before this. Yeah, so this, the nerve mobility,
Mhm.
that speaks to that same feature. When nerve becomes stiff, it does not move very well. So this would translate to elastography. So if you have elastography feature available, um, and you look at the elastography, you will see the nerve tissue will show like as a hard tissue. So if you have a machine which has scale from like red to blue, blue means like there's the harder tissue in strain elastography. This is going to show more of like stiffer appearance. And if the contralateral side is normal, you can compare, and you will see like different type of like stiffness scale there. A nerve will be more like pliable, not stiff compared to the symptomatic side. So yeah, I see like there is value in adding elastography if you have that available. The limitation at this point what we have is that it does not have very good norm. So it's not as quantitative as cross-sectional area, but can be definitely added if you have that feature available.
Mhm. We have another question.
Okay. Okay, so question is how often ultrasound can be used for nerve injury? What about the temporal cause of abnormalities seen during nerve trauma? Good question. So nerve ultrasound can be used. If you say often, I would say whenever you have a suspicion of nerve injury, ultrasound can be used. Now, injury can be like again different. There are different definition of injury, but peripheral nerve because it's so easily accessible with ultrasound, I would use it in every case if there is an indication. So that speaks to the first question that you asked. The second one about the temporal cause of abnormality. So because we talked about different um, pathophysiology and different mechanism that's happening, we tend to see more of hypoechoic changes in the nerve where there's constriction and enlargement. So now the size does not correlate to the grading, But what correlates is the change in echo pattern. The more you lose that honeycomb or fascicular texture, it suggests axonal injury. But if you just see endoneural edema and it just like shows like swelling and more engorgement, that coincides more with of demyelination or vascular congestion in the beginning. So that these are some of the features which you can use in informing, okay, how severe do I think this looks sonographically. And then there are also like some gray areas. So I don't use them as an absolute measure, but the more you see loss of that honeycomb texture, this nerve is undergoing axonal degeneration. So we know this is at least moderate, if not severe. In some nerves, you can see sometimes complete loss of this echo texture. Then those are more severe cases, and that correlates with EMG. You will see like loss of the texture, more stiffer looking nerve. It starts to become more of like fibrotic. That those will be more axonal injury and more advanced changes in the nerve. So these features can give you some information on like, how what's the temporal course of this abnormality as you're examining that.
Yeah. So I think no question. At last, I'm so happy to sharing us, Dr. Awad, and I hope in the next future, again and again, more cooperation with us in educational webinars. I think nowadays we emphasize on the mixing the ultrasound in as well as the electrophysiological assessment. Both can get a lot of informations, even structural
Yeah.
from the ultrasound as well as the physiological from the EMG nerve conduction. At the end of the talk, I will thank all the attendees as well as the Technia company for a great sponsorship for this Zoom meetings as usual and the support. Thank you so much. Have a nice day. Bye bye.
Thank you very much.
Thank you so much. Okay, bye bye.